Hello, everyone. Thank you so much for joining us today. So, I hope that all of are here already, but we're just waiting for a couple of minutes so that everyone can join. So, before we start, just want to let you know that yes, it should be probably a good idea to take this role play session in the night or at least in the evening. I understand that some of you might have some job or that's why may not be able to join in this time, but yeah, just just for some of the time we may need to start in this time, and we're going to start the role play session in a couple of minutes. Someone's video is on. Can you off your video, doctor? All right, so today's session is all about the role play, and as you know that AMC doesn't have any exam at the moment. It's because of the COVID situation that's been going on for the last 6 or 7 months. I understand all of you are frustrated, especially those of you who were planning to appear the exam very soon. I had so many people or so many students that they took the exam date, but still they're not able to appear the exam. So it's really frustrating for all of you, not only for you, it's for everyone. But we have to make sure that it doesn't affect our life, it doesn't affect our study or our aim or dream. Whatever goes on, you have to always pursue your dream. Now, some of the time it might not be what you have been expecting. You have to be prepared for all the bad situation. There are a lot more bad situation people are going on at the moment than you guys are on. But as I understand that it's stressing, I understand that yes, that some of you had some plan that you will start joining a hospital or joining as a GP in this year. That was your plan, and that plan might not be working. But trust me that everyone's plan is like in one way or other, it's delayed. So keep on your good work. If you feel distressed or upset, stop studying for 1 or 2 days. Go for some movie, binge movie watching, or do something which you actually like, and that will make you feel little better. So that's all. We'll start the role play session now. If anyone wants to participate in the role play session today, or the thing is like if you want to do role play with me today, make sure you guys that say yes when I say that if anyone interested to join the role play. So who is going to do the first one? Dr. Tasrifa, please come online.
Hi, doctor. Can you hear me?
Yes, I can. All right.
Okay.
So the role play session is, I think you guys already participated one of our role play session that we have taken like few months ago.
Yeah.
Um, yeah. So this is a 7 minute inside and a 1 minute outside. Normally in the exam you will get 2 minute outside and 8 minute inside. That makes total 10 minute. But no, in your real life, that means when you will be doing role play with your partner, try to make it like this, like 1 minute for thinking and 7 minute for your whole role play. So that will make an 8 minute session. So today we'll do that because in the exam always there will be some, like they say that they will give you 8 minutes, but there are like usually most of the time maximum 7:30 you will get. So always it's better to prepare for this sort of situation. All right. So I'm going to give you the first question, and after you have got it, then you will get 1 minute time to prepare, and then I will say, "Hello, doctor. What's your ID? Or can I please check your ID?" So then we will start, and I will give you the patient name at that time. All right.
Okay.
Okay. So we did those things. This okay. This is your case. So your 1 minute time is started. Hi, doctor. Can I check your ID, please?
Yes, examiner, this is my ID.
All right. So this is your patient. Your patient name is David. You can start.
Okay,
Sorry, just hold on. It's a very much noise in the background. Let me see. I'll just mute everyone. I think someone is. All right. Sorry.
okay. Can I start?
Yes, doctor. So this is your
Okay.
patient. Your patient name is David. You can start.
Mhm. Okay. Hi, David. This is Tashifa, one of your doctor today. How are you doing, David?
I, doctor, I'm not feeling good. It's been so
Mm-hmm.
distressing for me for the last 1 month. I can't even
Okay.
do my job now. It's hampering my whole life. My
Mm-hmm.
family is starving and it's so distressing for me.
Okay, I'm so sorry, David. I know it's really distressing situation for you, but don't worry, David. I am here. I will try my best to sort out the cause. Okay.
Yes,
So,
doctor, yes.
David, can you please tell me more about you? Like, what do you mean by you feel distress? What's exactly
Um,
happened?
um,
Let me assure you that whatever we are going to discuss it remain confidential, so you can share with me anything. Okay.
yes, doctor. So I feel like, like I'm a farmer and I need to go out and do the farming and everything. But
Mhm.
recently for the last 1 month, I'm feeling like my whole body, especially my whole hands are really contaminated. And I feel
Mhm.
like it's full of germs. And I
Mm,
keep thinking it again and again. And I keep
right. Mhm.
like it's so distressing. I always in my mind, it's just like that I will get something very bad
Right. Mhm.
from these germs. Yeah.
Okay, okay, yeah. I know, you were farmer and you have to do a lots of work in your farmhouse, and that's why maybe you were thinking you may be contaminated, right? I know it's really distressing situation for you. So you feel this type of feeling for last 1 month, right?
Yes.
Okay. And do you notice like this feeling comes in your mind again and again, and you couldn't resist yourself?
Yes, doctor. I try my best to resist, but
Okay.
yeah, I
Mm-hmm.
can't.
Okay. And if you try to resist it, what you are doing that time?
I can't actually. It makes me like really distressed, and then I
Yes.
have to do something
Mm-hmm.
to get rid of these thoughts that I need
Mm-hmm.
to wash my hands again and
Mm-hmm.
again.
Okay. Right. And how many times you wash your hand? Did you remember?
Initially, it was just 4 or 5 times a day, but now it's
Okay.
like I can't even remember like how much I have to do. Like
Mm-hmm.
some days it's 40, 50 times I do that,
Okay. 40,
and
50. Okay. And after when you washing your hand, you feel relief, right?
yes.
Okay. And apart from this thought, any other thought that coming in your mind?
No, doctor.
Nothing. Okay. And David, is that all right? May I ask you a few more
Yes.
sensitive?
Hello. Yes,
Can you
doctor.
hear me? Okay. Would I ask you a few more questions? But few question might be sensitive, and some of our screening question. Is that all right for you?
Yes.
Okay. So, how's about your mood recently, David?
Yeah, I'm not feeling good, doctor. It's just distressing or upset. I am.
Okay. Mm-hmm. And on the scale of 1 to 10, how you rate it?
I don't know, doctor.
Okay. And anytime if you feel any high mood and low mood,
I feel low mostly.
okay. And how about your sleep and appetite?
Yeah, it's all right, but still my appetite is getting lost.
Your appetite is also lost, and for the same duration.
Yeah.
Okay. And your sleep is fine?
Yes.
Any nightmare, any in the mid of the night you just woke up? Any problem?
No.
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 Okay. And David, I'm going to ask you a few more questions that might be weird, but please bear with me, okay?
Okay.
Anytime do you feel thought to harm to yourself or any type of thought to harm to others?
No, doctor.
Do you feel like life is worth living?
Yes.
Okay. And by any chance, do you see something weird, or do you see some voice that other don't?
No.
Okay. And David, may I know whom do you live with?
My wife and my son.
Okay. Do you have enough support from your family?
Yes.
Any stress going in your family or any stress related to work?
No.
Okay. David, are you generally anxious person?
Yeah, I'm quite anxious person, doctor.
Okay. And okay. Do you notice any particular situation you feel more restless, you feel more anxiety? Any particular situation?
No.
Nothing. Okay, that's fantastic. So, David, do you need professional help for this your
Yes, I
situation?
think.
Okay. And what about if you suppose if you see fire in the room, what you are going to do?
I'll run away.
Okay, that's fantastic. And David, may I know, like recently, do you have any fever, any flu-like illness,
No.
any trauma history recently?
No.
Okay, any other like any weather preference or any bowel habit changes?
No.
Any smoking, alcohol intake?
Mm, no.
By any chance, any recreational drugs you are using?
No.
Okay. Do you have any past medical or surgical condition? Any type of similar problem that you experienced before?
No, doctor.
Any of the family member experienced similar type of condition?
My father had schizophrenia. That's all.
Okay, okay, thank you. So how's about your father now?
He's gone, doctor.
Okay, I'm sorry. So David, thank you so much for all of your information. David, based on your history, what I'm suspecting you are having a condition, we call it obsessive compulsive disorder. Okay, don't worry, I'll explain you. Obsessive compulsive disorder is one kind of anxiety disorder. Okay, when you are thinking excessively in one thing and you couldn't resist yourself, and that's why to compensate this behavior you are trying to do repetitive hand washing. Are you following me?
Yeah.
We call this condition is obsessive compulsive disorder, but don't worry, it's a manageable condition. Okay, what I am going to do is that I would like to give you psychologist referral. They are going to give you some cognitive behavioral therapy. Okay, like just a talk therapy. They try
Time
to
up.
uh,
Time up, doctor. All right. Thank you so much, Dr. Tasrifa. It was really nice, and I really liked your approach and everything. If you continue in this way, it should be really, really good. I would say that the approach is the vital part in your exam. If your approach is good, even though if you make some tiny mistakes, the examiner will not bother with that. So the approach, that how you approach a patient, your tone, voice, like we all have like our particular voice, but the tone is the one of the important part. When you talk, like your tone should always get changed with some particular situation. Now in this case your tone should be like how Dr. Tasrifa's tone was, like always it should be like something calming and polite and gentle. It's very important to adjust your tone with the particular situation patient coming to you. If a patient is crying in front of you, your tone should go down. It's it's showing that yes, you are also feeling empathic with the patient sorrow or sadness or something like that. So that's a very vital part. Many people or many candidate is lacking in that part because they think that this is just a simulation and this is not a real scenario. Even if the patient is crying in front of you, it's just a acting. So you are not showing your empathy by lowering your tone or by adjusting your tone, which is a very important part for passing this kind of exam. So it should be like a realistic kind of thing. So always we need to make sure that. So that's a good thing, Dr. Tasrifa, you maintain. The second one that you said about the confidentiality, if you would not give me the confidentiality, I would not give you any of the findings. That's very important. So once you go in this sort of cases, it's a psychiatric case, as you can see, that patient feeling distressed. And it's a vague case that in the 2 minute outside, you will not understand what's the case about, right? When you go in, when you will ask that, can you please tell me more about what making you feeling distressed? Please don't worry. I'm here to help you. And whatever you talk to me today, it's going to be confidential. You don't need to feel judged. You don't need to feel ashamed about any feeling you are having at the moment. It's totally fine and it will be totally confidential. So talk in a way patient feel confident that yes, I can talk with this doctor. Okay, that part is vital for psychiatry. Psychiatry is not about just asking question and just telling or just explaining the condition. It's about making a relationship between a doctor and a patient, because this patient will come to you again and again with the same problem, right? So you have to make a rapport with the patient at the first visit. That's the vital part. How you make rapport, that's important. You will hear that some candidate did not get exact answer from the role player, or the same exam situation, same date, but the other candidate got all the information that she needed to pass that case. So it depends on how you asking question to a patient, how you maintaining the rapport with the patient. So that's important. So in this case, we will start asking in that way that, yes, can you please tell me more about what's going on? And say all those good things. Now, this was actually a case of OCD, so obsessive compulsive disorder. In obsessive compulsive disorder, we usually follow a format. That means we go in detail about the thought process patient is having. So duration is important. So how long you are having these thoughts? Anything particular happened at that time? So Dr. Tasrifa, I will give your feedback during this discussion, all right? So
Okay.
one of the important thing is that we need to ask that anything particular happened at that time when this all thoughts has started. Why we are asking that? Patient with adjustment disorder have some stress in their life, and in response to those stress, they started to feel something different, something abnormal. So we always try to rule out adjustment disorder in any of the anxiety disorder cases. So we can ask like anything particular happened during that time. So usually with the conversation going on, you will understand what's the thought patient is having. So then you can ask like how often you have this thought. Do you think that these thoughts are excessive and unwanted? Because this OCD patient, they know that these thoughts are excessive. These thoughts are unwanted. They know that. That's make it OCD, because OCD patient has insight. And then you can ask like, have you ever tried to resist this thought? Yes, doctor. So what happened when you try to resist it? Doctor, I feel more distressed. I can't resist it. So what you do to make sure that you feel better? So that's the compulsion question. Yes, doctor, I wash my hand a lot of times. So how often do you wash your hands? So normally, initially, it will be like for a couple of times. Then it's get gradually, it will become more and more increasing. So that's your thought question. So you have got the obsession, you have got the compulsion. Then sometimes apart from one obsession compulsion, patient can have multiple thought disorder. So you can ask any other thoughts coming to your mind, or do you do any other abnormal behavior or abnormal repetitive behavior apart from this? So we need to make sure that is there any other thoughts coming to the patient mind or not. After you finish your thought question, then you go to the psychosocial history. We discussed in our first trial class about the psychosocial history, if you guys remember, or if you had done our that class. So psychosocial history, we are not going to discuss it today. So you have to mainly in here mood, sleep and appetite, then suicidal thoughts. Just one question about the hallucination. That means, do you think or do you see, feel, or hear things that others don't? Just one question. In here, you will not get that much time to ask whole psychosocial history, and don't do that. Okay, so just ask about that. How is your mood these days? Then how about your sleep and appetite? Just one question. You don't need to even go into the sleep nightmare, those sort of things, because that will obviously kill your time. So mood, sleep, appetite. Then one thing, that do you have any passing thoughts of harming yourself or others? Then do you feel, see, or hear things that others don't? Then do you think that you need any help? Just that. Even judgment is not very important. So mainly psychosocial history, mood, sleep, appetite, suicidal thought, and hallucination question, and the insight question. After that, your heads is very important. Heads in here, stress, that how about your home situation, any stress at your home, any stress at your work. So these are more important in these cases. After that, now OCD patient usually have some personality disorder. So you can ask like, are you perfectionist in nature? Normally they are quite a perfectionist. So this one is a very important question. Also, Dr. Tasifa, you missed. So make sure this perfectionist in nature is important to ask. Now, always try to rule out some of the differential diagnosis. What are the main DD in this case? It could be generalized anxiety disorder, which Dr. Tashrifa, you have ruled out. You also ruled out phobia. You ruled out depression by asking psychosocial history. You ruled out substance abuse by asking SADMA, right? And adjustment disorder, you also ruled out by asking this question. So see that normally you have ruled out most of the question, but generalized anxiety disorder. So you can say, so do you, are you an anxious person normally? Or do you worry a lot about most of the trivial things? So any of these questions are okay. Phobia, so are you afraid or scared about particular situation or particular thing? So that's for a specific phobia. So just ask couple of normal differential diagnoses, ask about past medical history, ask about some of the medical differential diagnosis, especially hypothyroidism, any current illness, especially any upper respiratory tract infection or head injury. This usually not very common, but always we try to rule out medical related differential diagnosis, which normally hypothyroidism, head injury, and infection. Just three questions. And then lastly, family history of mental problem. So that's your format in psychiatric history. So start with the HOPC, or history of presenting complaint, which is the thought problem. Then psychosocial hits, in this case, differential diagnosis related to psychiatry, differential diagnosis related to medical, then past medical history, family history, SATMA. Okay, so that will be your main history. Now always, if you feel like you don't have much time, you don't ask about medical DD. So try not to ask everything in your exam, because you may not be able to finish your case in that time. So normally, if you at least go through the thought question properly, psychosocial history properly, and heads properly, usually that's okay. Now, explanation of OCD is very important. Explanation should be in this way, that say that, well, from your history, it seems like you are having a condition called obsessive compulsive disorder. Do you know what it is? No, doctor, what it is? Well, let me break the term for you. So you are having obsession as well as compulsion. This is a kind of anxiety disorder which has two subtypes. First is your obsessions, which is recurrent, persistent, abnormal thoughts, which you also know that these are excessive and unwanted. You try to resist it, but you feel more distressed when you resist it. So you have to do something to make sure that you feel better. And that's your compulsion. So in your case, your obsession is that you are thinking about contamination, germs from your outside worlds, and you're trying to resist that, but you can't, you feel distress. So that's why you keep washing your hands, and that's your compulsion. So always try to make the patient understand that what is it the condition patient having, and try to incorporate the symptoms of the patient with the condition. So as I said, like, what is obsession is these are kind of abnormal, excessive, recurrent thought which you cannot resist. In your case, is the fear of contamination. And you try to resist that, but you can't. Now to make sure that you feel better, you do some abnormal repetitive rituals or behavior. That's your compulsion. In your case, that's the repetitive washing of your hands. I understand it must be very distressing for you and must be very time consuming for you as well. And it not only affects your life, it affects your social, occupational, and familial life as well. I'm really sorry that you are going through this. But please don't worry. Now that you are here with me, I will try my best to make sure that you feel better. First of all, I would refer you to a psychologist for a spatial talk therapy, which we call exposure and response prevention. Always try to explain this CVT, particular CVT, you should explain to the patient. So what is exposure response? Exposure involves that confronting what you actually fear or confronting to your abnormal thought process, while the response prevention is gradually making you feel better to resist those feeling or resist those thoughts. So normally exposure and response prevention is that the psychologist will gradually confront you the particular things you are thinking about, and gradually they will make sure that you can resist that with with small improvement. All right, that they will not ask you to totally stop your washing. They will gradually confront you with those situations and gradual cessation of the behavioral disturbance. So if you want to explain exposure response prevention, say that, well, exposure involves confronting what you fear, while response prevention is a gradual cessation of behavioral or mental disturbance associated with it. Also, if you don't feel better with the psychologist therapy, we can always refer you to a psychiatrist who will start you with some medication called SSRI. There are lots of support groups for this kind of condition. You can go there and you can talk with the other patients having the similar problem like you are having, and you will feel much better at that time. Also, try to make some lifestyle modification, try some relaxation techniques like yoga, meditation, and I'll give you some reading material about all I have talked about. And again, I will review you in 1 month's time. If anytime, if you feel that it's getting really distressed and you are feeling that you want to harm yourself or others, please, please don't, please before doing any of it, you can call me in my number or you can come back to me immediately at any time. So always give a red flag. In this case, red flag will be excessive distressing, that the patient goes at the age of harming themselves. So always give a red flag. Clear? So in this case, like it may take a lot of time to say all these things. So that's why if management is a task in this case, try to finish the history within 4 or 5 minutes so that you can talk, because in here there's a lot of explanation. Clear, everyone? Dr. Tasrifa, you did really good. Don't worry. But I would say that your history is absolutely perfect. You will get 7 in history, but if you don't get 4 in your explanation, that doesn't help you to pass the case. So you have to make sure that you get 4 in every task. Okay, so that's the main issue. Dr. Nandika, the first task was to take history, not MSc. Should there be any change of the question that she asked? So we actually did not, I think like it's kind of same that your MSc or psychosocial history is most of the time is a similar question, but we don't actually need to ask about judgment in then your cognition, which we ask in MSc. We can just ask mood, sleep, appetite, suicidal thoughts, and one question for hallucination. Even if you don't ask it, that's fine. And insight. Even if you don't ask insight, that also fine, because patient came to you with the problem. If the patient did not come to you, that means that patient doesn't have insight. Now patient comes to you saying that these are unwanted and excessive. Obviously patient has insight. So even if you don't ask that, that doesn't make anything different. Any question from this condition, from this case? Who was having the problem with the audio? I don't know your name because it's not showing here. If you have any problem hearing, make sure you adjust your microphone with the Zoom audio settings. I think that will help. Or you need to at least join your computer audio with this Zoom, then you'll be able to hear. For social life, especially, you need to ask about that. You can ask like, well, how about your home situation? Who do you live with? Are you a happy family? Okay. Then any stress at your home or any stress at your work? So the red flag is mainly you will have to say to the patient that, well, if anytime if you feel really distressed that you want to harm yourself or others, please come back to me. All right, so let's start with the next role play session. This session will be for 1 hour, so we'll try our best to do as much role play as we can. No, he doesn't need immediate referral to psychiatrist. Normally, you will try the CBT first, that means the exposure and response prevention. If that doesn't help, then we can send to the psychiatrist. Clear. Who is going to do the next role play? Dr. Sajia, please come online. Okay, I think someone else asked before. Yeah, sorry. Dr. Sajia, you will do the next one. Who is Dr. Mukta? Yes, please come online. Just give me a second.
Hello.
Yes, doctor.
Yeah.
Okay, just hold on a second. So this is your case. Your 1 minute time is starting. Just give me a second. This is your case. Your 1 minute time has started. All right. Hi, doctor. Can I check your ID, please?
Yes, examiner, this is my ID.
So this is your patient. Your patient name is Lisa. You can start.
Okay, thank you, examiner. Hello, Lisa. I'm Dr. Mukta, one of the doctors here. Today I'll be taking care of you. So, Lisa,
Yes,
how
doctor.
are you today?
I'm not good, doctor. I'm feeling very nauseous, and I think I'm going to puke again. And it's really bad. I can't keep anything down, and I feel so nauseous now.
I'm so sorry to hear about that, Lisa. Lisa, so can you tell me, if possible, can you tell me more about your vomiting, like since when and what is the color of your vomit?
For the last 2 days I'm having this problem, and
Mhm.
it's whatever I'm taking in is coming out.
Okay, I see. It must be very distressing for you, Lisa. But Lisa, now you are here, so I try my best to help you out. Okay.
Yeah,
Can you tell me, like, is large amount or a small amount? Is it a smelly?
yeah, it's quite foul smelling.
Any blood do you notice?
No,
Otherwise, Lisa, do you have any chest pain, any funny raising of heart?
no,
And do you have it? What about your bowel movement? Like, are you regularly passing your bowel?
yes, doctor.
Any loose motion?
No,
Are you running any fever or any rash?
no,
And what about your pee? Like recently, any decreased pee? Do you notice?
yes, doctor. I'm not being much.
Okay, may I know since when it's going on?
It's started with this vomiting. I'm
Mhm.
not going into the toilet much now.
Okay, I see. So, and also, I just want to know about your, from the note, I also come to know that you are diagnosed with high blood pressure. So, and also you are in medication. So, may I know, are you taking medication regularly at the prescribed dose?
Yes, doctor.
And are you regular with your checkup?
Yes.
Any recent dose change, like increase or decrease the dose?
No, doctor. They just recently started this one painkiller for my joint pain.
Okay. So, since like when it started?
Just 5 days ago.
And after that, you are feeling like that?
No, doctor. I'm feeling this like for the last 2 days.
Okay, I see. And also, I just want to know for the, you have some kidney problem. For that, are you taking any treatment?
No, doctor. I'm not taking any treatment.
Okay, I see.
Just
And
the medication.
also, sorry?
Just these are the medication I'm on.
Okay, I understand. And otherwise, do you have any high sugar or high cholesterol?
I have diabetes, but no, I don't take any medications for that.
Okay. And do you have any family history of any kidney problem or any high blood sugar or high cholesterol?
No.
Okay. Thank you for your all information. Now I'll talk to the examiner about your condition, then I come back. Okay. Just wait for a while.
Okay.
So Lisa, hello examiner. I want to order some investigations.
What do you want to order?
First of all, I want to order the ECG, and also I want to order some blood tests, mainly the serum electrolyte.
So this is the ECG you ordered?
Okay. Sorry, doctor, I have to say that about ECG, interpret. Okay, thank you. So, examiner, here this is, may I confirm the name and date of birth of my patient?
Is your patient ECG?
Okay, and here the um, heart rate is 75 beat per minute and is regular, and POF is followed by QRS complex. But here I observe tall TOF in V1, V2, V3, V4, V5, and V6 leads. So, examiner, my interpretation is this ECG shows hyperkalemia.
Okay.
So, may I go to my patient back? Oh, okay.
This is the blood test you ordered?
Yes. Okay, examiner, I want to talk to my patient. So, Lisa, thanks for patience waiting. Now, I have done your blood, I have taken your history and ordered the investigation, and I have seen your ECG, and also I have seen your blood test results. So, what I'm suspecting, you have a condition called hyperkalemia. Have you heard about it?
No. What is this, doctor?
First of all, this is actually, we have some minerals in our body, which one of the mineral is potassium, which increase in your body. Are you with me so far?
Yes.
So it might be due to other reasons also, like it might be due to acute or chronic renal failure, because your previously you have your kidney function is a little bit compromised, and now due to some electrolyte imbalance it might be aggravated, or it might be due to some medication induced and what we called is triple OME, because you are taking AC inhibitor and also you are taking diuretics, and also recently you have taken analgesic. So we call 3 drugs as a triple OME, which also responsible for your nausea and vomiting and also feeling unwell, because these actually combinedly causes high potassium in the blood. Are you with me so
Time out,
far?
doctor. Your time is up.
Oh, sorry.
Yeah,
Sorry, I actually
it's
didn't
okay.
hear properly.
No, no, yeah, you did good, Dr. Mukta. It's really nice that you covered most of the things that's needed to pass this case. So a little bit of the improvement we can say
Mm,
about the diagnosis and differential diagnosis that we can explain in other way. I will just show it to you. Otherwise, everything is good. The history, you covered most of the thing, but like normally this case is, see that this patient is having previous history of chronic renal failure
mm,
and recently started having nausea, vomiting, and patient taking these medications which can also cause renal failure. So
mm,
this ACE inhibitor usually we don't give in chronic renal failure patient. Same like furosemide, sometimes we give, sometimes we don't. And also the diclofenac. These three can cause acute renal failure, obviously.
mm,
So patient with acute renal failure, they can have this nausea, vomiting also because the toxic substance they are not able to excrete. So that toxic substance can cause nausea, vomiting. Now, we can think in many ways in here, but this case is mostly acute on chronic renal failure. If your kidney is not working, normally what's the kidney's job? Kidney's job is to excrete potassium and retaining the sodium and water. So your kidney is not working well, so you are retaining potassium. That's why you are having hyperkalemia.
mm,
That makes sense. Otherwise, like if we think that the nausea, vomiting causing the renal failure, that doesn't work. Because if it was nausea, vomiting causing renal failure, then the potassium should go down, right? It should be hypokalemia.
mm,
Because if you are vomiting and then you are losing obviously potassium through the vomiting, that should cause hypokalemia. And sometimes pre-renal failure can be caused by like excessive vomiting. But
mm.
this case is not about pre-renal failure. This case is
Yeah.
renal failure. Yeah. So
Can
would,
I add something, doctor?
yeah, sure.
Actually, I that time I want to say, maybe I doesn't make you understand properly. Like if triple OME there, and also you have dehydration. So that time due to fluid loss, also it apparently causes high potassium. Like potassium is maybe normal level, but whenever there is fluid loss, it's also aggravate.
Yeah, like that's possible, but normally it's not that like the
Mhm,
usually for sodium that is all right. Like
mhm,
sodium sometimes if you get dehydrated, your sodium can get up. That's
mhm,
okay. But for potassium, it's not that much common that like dilutional hyponatremia or
yeah,
hypernatremia
yeah.
or the dehydration causing hyperkalemia. It's not that much. If this patient did not have previous renal failure history, then we could think in that way. But a patient who already has chronic renal failure, most likely there's a renal failure getting aggravated again
Mhm,
due to the medication. Because the recently starting the diclofenac, that actually make the renal failure more worse. That's usually these sort of cases we would always try to say the diagnosis as acute on chronic renal failure. That's usually a better idea.
mhm,
Normally, yes, dehydration can cause hyperkalemia, but it's not a very common cause. Common cause
mhm,
is these things.
mhm,
All right. So the in here we will this ECG explanation was good. So normally I think we talked about ECG explanation. I don't know with you guys. No, we haven't. So normally if we explain ECG, always like as Dr. Mukta has said that yes, I want to confirm the ECG with my patient. Yes, we can do that. And then always we start with the P wave followed by QRS complex, then ST wave, then go for the T wave, and lastly QT interval. That's the main flow. So P, that means first you say about heart rate and rate rhythm first. In here, the heart rate is, yeah, it's could most likely, sorry, 75, yes. So rate and rhythm, you can see these are all regular rhythm. So first rate rhythm, then P wave, absent or present, normal incision, shape or not, followed by QRS complex, is it narrow, broad or normal? Then ST changes, ST depression or elevation, then T wave. In here, obviously, we can see the tall peak T wave in these cases. And lastly, QT interval, increased or decreased or normal. So we'd say that, well, this is the 12 lead ECG of my patient showing heart rate of 75 beat per minute, rhythm regular, P wave normal in size and shape, followed by QRS complex, which is also normal in size and shape. There is no ST wave changes. T wave is tall, peaked in most of the lead, especially V2, V3, V4, and V5. The QT interval seems to be normal. So from the ECG, I'm suspecting this patient is having hyperkalemia. So this is how you can explain. Your explanation was good, Dr. Mukta. Then we can see this patient is having hyperkalemia. Now, your investigation is not only about ECG. We will ask about full blood count, then kidney function test, which is mainly urea, creatinine, GFR, and the electrolytes. So you have to ask not only the electrolyte, you have to ask about kidney function test as well. All right. Sometimes you can also ask from the examiner that, examiner, can I have the any recent investigation to compare this kidney function from the other result? Because we don't know that this GFR is the baseline for this patient or not. Some of the patient has 32 GFR for 1 year, right? We don't, so it's a good idea to ask the examiner that, examiner, do I have any recent kidney function test and the serum electrolyte level, just to compare. So that's a very good idea. The examiner can get uh, more comfortable with you, or they can sometimes, they really love that you know these sort of things. Because in Australia, when you will be doing when you'll work as a doctor in GP setting or in the hospital, you, in your computer, you will get everything available, like the from the last 15 years, whatever the kidney function was there, you can see it normally within second. So that will help you to understand the patient baseline. Now, it's what about ABG? You can ask about ABG, but not very helpful in here. But asking ABG is good. You can ask ABG or VVG in this case as well. Now, normally in this case, if you go into the format, your format of history should be like that. So always in your mind, make a format that how I'm going to ask the questions to this patient. So patient is complaining about nausea, vomiting. Always in these cases, if a patient is vomiting in front of you, you should say that, well, please don't worry. Now that you are here, we will take a good care of you. Now, would you want me to give you some medications to relieve your vomiting? Yes, doctor, that would be really good. Do you have any allergy to any medication? No, doctor. So I'm going to give you some antiemetics medication so that you feel comfortable. Give some antiemetics. That's very important. All right. So first of all, you give the patient some antiemetic medication, and then you start asking your question. So your HOPCU is vomiting. So ask all the questions of vomiting. So since when it's happening, how like, is it a small or large in amount? Any blood in it? Is it foul, smelly? So just a normal vomiting question. Then always with vomiting, we have a associated question to ask so that we can rule out some of the important DD just by associated symptoms. So we can ask that any fever, any tummy pain, bowel habit, bladder habit. Always remember GIT symptoms has 4 different things to ask. So nausea, vomiting is a kind of GIT symptoms. With any GIT symptoms, always we ask 4 things. First is your nausea, vomiting, then fever, then tummy pain, then bowel and bladder habit. Okay. Now in gastro also we can offer antiemetics. The thing is, like, if a patient vomiting and this patient most likely, like, she's so uncomfortable that she's keeping the ball in front of her, something like that, it will be the scenario. So you should give antiemetics. Anytime if a patient is so much in pain, the patient will be unable to give you a history because of the pain. So offer painkiller before you ask any question. Patient is vomiting in front of you and you are asking question. That doesn't seem right. And this thing examiner doesn't like at all. All right. So you have to offer antiemetics if a patient vomiting or say that, doctor, I'm feeling so nauseous at the moment. So give some antiemetics. That's actually the way of asking to you that you should give an antiemetic to this patient. And you get a tick that yes, you have given antiemetic or painkiller to this particular patient. All right. So nausea, vomiting, fever, tummy pain, bowel habit, bladder habit. Now, in this case, as a patient is vomiting so much, you can ask about hemodynamic stability from the examiner because it's the acute onset. In any acute onset thing, we always try to ask about hemodynamic stability. That means you can say, I can see you are really distressed, Lisa. Please don't worry. Now that you are here, we will make sure you feel comfortable. Do you want me to give you any medications to relieve your vomiting? Yes, doctor. Do you have any allergies? No. Well, I will give you some antiemetics at the moment. Before I ask you any more question, I would like to go to my examiner, make sure you are stable. So you can say that, doctor, is my patient's vitally stable for further history? If it's already given in the stem, yes, we will not ask it. That's why actually Dr. Mukta also didn't ask, if you see. So normally, if that's also one important thing, because we all know that in acute cases we ask about vitals, but most of the time vitals will be given in the stem, but still you will ask it. An examiner gets very angry when you do that, because it means that you have not you have not read the stem properly. All right, it's very important not to ask anything what's already given to you. No, don't think in very complex way. All right, Dr. Tasrifa, that this patient is in front of you. It means that the vitals just now they have checked. No need of double checking. All right, this, don't overthink or don't think in that critical way. Think always very simple. If they say that vital is stable in the stem, well, I'm happy with that. But in the PEFE, you can ask that, doctor, I know the vitals has already stable according to the stem, but is it still the same? You can, if you have time, you can do that. But this thing actually wastes your time in the exam. By asking vitals again and again, it will just waste your time, nothing else. After you have done your all these things, nausea, vomiting, fever, tummy pain, bowel habit. In the bowel habit, if a patient is having nausea, vomiting, you should rule out intestinal obstruction, all those, then gastroenteritis, right? These are important DD. So patient will not have any tummy pain, so less likely to be intestinal obstruction. Still, you can ask, how about your bowel habit? Any diarrhea or constipation? When was the last time you opened your bowel? How's your water works? Any burning sensation in your urine? And do you think your urine output is good, or do you think your urine has been decreased in amount? That's a very, very important question. Dr. Mutta also asks that because this is a renal failure case, urine output can get significantly dropped down. So we have to ask that. All right, this is very important. Then this patient, we will think that, well, most likely this could be a renal failure given the look of the stem. So ask about the causes of renal failure. Always there are three causes: pre-renal, renal, post-renal. So for pre-renal, already we have vomiting. We have asked about diarrhea. We can ask about, have you having any excessive sweating, any burn, any bleeding from anywhere? All right. Also, you can ask any swelling of your legs or in your tummy. Why? Because liver, mainly the heart failure can cause pre-renal failure as well. So you can ask about a heart failure question. That means any shortness of breath, any swelling in your legs, any history of heart condition or heart failure. So that will make sure that you ruled out pre-renal failure. Renal failure, patient already having chronic renal failure. You can ask something about that. You can say, I got to know from the nose that you are having renal failure. Are you on any kind of treatment for that, especially any dialysis? So dialysis history is important if the patient is having dialysis or not. Then post-renal, for female, post-renal is not very important, but sometimes bladder cancer or any bladder stone blocking the outflow, they can cause it. But post-renal in female is not very important. Then symptoms of renal failure. Renal failure patient will not only have nausea, vomiting, they can have other features. So ask those symptoms. So do you feel weak and tired? Any itchiness in your body? Any numbness, tingling sensation? Any swelling or puffiness? Shortness of breath? Chest pain, racing of your heart? These are very important questions, symptomatic questions, because chronic renal failure can have swelling, puffiness, they can have shortness of breath, itchiness is very common, neuropathy is common. So you can ask this question. Dialysis history already you have asked. If the patient say, yes, doctor, I'm on dialysis for that, you have to ask that, when was the last time you had your dialysis? When is your next dialysis is due? And how long you are having dialysis? Medication and medical history. Very important in here, the medical history. Sorry, the medication history, because patient is taking some medication which can make the renal condition much worse. So you have to ask the details. So I know from the notes you have been taking some medication. Are you taking this medication in the appropriate dose? Any chance you have been taking it in like in excessive dose or more than usual? Any recent change of the dose? Any recently any medication is you have started? So patient can say, yes doctor, they have started the diclofenac recently. So this medication history is very important to ask. So mainly drug history, we have to ask that, well, I know from the notes you have been using some medication. Any recent change in the dose, or you have taken any excessive dose? Any new medication have been added? Then also ask about other medical condition apart from hypertension and chronic renal failure patient is having. So that is your main history format. If you follow this format, you will not miss any of the key steps. After that, you will ask the investigation, then explain the ECG to the examiner, and then come back to the patient. To the patient, you have to explain what the patient is having. Now, mainly in this case, you will explain in a way that, Lisa, thank you so much for waiting. Now, from the history and also the investigation results, I'm thinking that you are having this nausea and vomiting because of a particular condition called acute on chronic renal failure. I'm really sorry for all these medical terms. Please don't worry. I'm going to explain it in easy words. Now, let me draw a picture. So this is your kidney. The function of your kidney is to remove any toxic substance from your blood in your urine. If due to any certain reasons, your kidney function is deteriorated, for example, some medication, some medical conditions, or even sometimes severe dehydration because of vomiting, diarrhea, or severe bleeding, your kidney function can get more worse than before. I'm suspecting that already your kidney is compromised and you're taking some medication, especially they have started this diclofenac with your previous medications, which is very notorious to cause kidney function deterioration. I'm suspecting your kidney is more worse than before and it's unable to remove any toxic compounds out of the body. And that's causing the nausea and vomiting. Do you understand me so far? So normally in this case, you have to say that this is your kidney. Your kidney is already compromised. I'm really sorry to know that. But your kidney's job is to remove the toxic compounds out of your body. As you're taking some of the medications, these medications most likely causing your kidney a lot worse than before. That's why your body is unable to remove this toxic substance causing the nausea and vomiting. Also, your kidney job is to excrete the potassium kind of minerals in our body. But as your kidney is not working, your potassium is retained in your body, causing high potassium level in your blood. So you can also say that. So you say that patient is having acute or chronic renal failure, patient is having hyperkalemia as a complication of renal failure. All right. Now, other DD, you just give your pre-renal failure causes, renal failure other causes, and post-renal failure causes. So you can say that, well, sometimes kidney failure can happen due to other causes as well. Like sometimes if you lose excessive fluid from your body, like vomiting, diarrhea, excessive sweating, burn, bleeding from anywhere, that can also cause your renal function getting deteriorated. If you have heart failure, your kidney will not get enough blood, so that can also cause it, but you don't have anything like that. So that's unlikely. Some other medications also can cause it, but you are not taking any other medication apart from this, so that's unlikely. Sometimes the medication can cause toxicity that we usually call it like tubular, like acute tubular necrosis, those sort of things. But I would rather not say this to the patient. It will just make the patient more uncomfortable. So you just keep it simple. Say pre-renal failure. Already you said renal failure. Also, sometimes if you have any blockage in the flow of the urine out of your body, that can cause it. But you are not retaining any urine. You are not having any tummy pain. So that's also unlikely in your case. Okay, so that will be your explanation. Mainly, you should say that it's the acute or chronic renal failure. What's the underlying cause? Cause is the medication. And also due to renal failure, you are having hyperkalemia. Other causes could be pre-renal failure. Just give all those causes and give the post-renal failure causes. All right, if you say that, that should be fine. Management in this patient will be admission to the hospital. Then obviously the nephrology involvement is a must, and you will stop this medication. So you have to stop the painkiller diclofenac, also stop the diuretics for 24 to 48 hours, see how the patient is doing. Okay, and then depending on how the patient progressing, the further treatment will be given by the nephrologist. Now, this patient is having hyperkalemia with ECG involvement that also needs to be sorted out. So you have to give calcium gluconate, insulin plus glucose, salbutamol, even sometimes resonium if needed. So normally this case doesn't come as a management because it's already so big. So keep it simple always. Clear everyone? Any question? Now, Dr. Umara, yes, you can give ondansetron, that's fine. Like a small dose of ondansetron doesn't make the renal function worse. Now, who asked about Dr. Nandika? Yes, obviously you can ask ABG. That's fine to ask. In any failure, ABG always helps. It's not always. In renal failure, it's not always hyperkalemia, but normally, yes. There is not always anywhere, but normally, usually, yes, hyperkalemia is one of the thing. In a patient with acute renal failure, you will get hyperkalemia, as well as in chronic renal failure, you can get hyperkalemia. Sometimes in the end stage, you can even get hypokalemia. But in acute renal failure, always hyperkalemia. So DD, all like in here, there is no specific, you cannot say renal fail, like this case is not about like lot more DD. This case is about a patient having multiple conditions, and now on the top of that multiple condition, patient has an acute condition, and what's the cause of that? They will ask you like that, like diagnosis with reasons or diagnosis with differential diagnosis. Differential diagnosis in here will be related to the causes mainly. So it could be, first of all, you will say acute on renal failure causing the hyperkalemia because of the medications. Now, others, it could be heart chronic, like it could be CCF, that means congestive cardiac failure. It could be severe sweating, burns, excessive bleeding from anywhere, or it could be blockage in anywhere in the outflow of the urine. Sometimes others, like other medication can cause nephrotoxicity. That can be a DD also. So these will be your DD mainly. You have to say at least 4 or 5 differential. ECG slide. What is the ECG slide? This is the ECG. So in this case, in the ECG also, this ECG, if you look at, this patient is having like broad QRS complex. So I haven't actually said that, I think. So this patient is having this broad QRS complex because normally QRS complex should be 1 to 3 small square. If you measure it, it's more than 3, like about 4 or 5 small square. So yes, this patient is having broad QRS as well. So we'll stop here today. Already it's been late today. So we'll do some other cases in our next role play session. We will give you some time. Okay. Sorry, I think my plan was to go for 4 cases today, but I think this case was a little confusing for many of you. At least I think that this case is now solved, right? So we will do some more cases in our next sessions. Thank you all. We'll give you some update, Dr. Wafi. Thank you all for joining. And it's really good that you're still coming to the role play sessions and doing the role play. That helps many of the new beginner also. The both of you, Dr. Mukta and Um, who has done first? Dr. Tasrifa. Yeah, so both of you has done really good. Keep up your good work. Thank you all. Bye.